you have your mic? Are you hooked up?
What? No, I'm not. Is there
Oh, I guess.
a...
No, they don't have one. You're good. Yeah. All right, good afternoon. So welcome to Psychiatry Grand Rounds. Today I have the pleasure of introducing our speaker today. Karen Floyd is currently a chief resident in our program. We're very fortunate to have her here and her expertise. Karen graduated from Des Moines University in Iowa. I have to correct myself because anybody from Iowa will mug me on the way out. And she graduated from the University of Minnesota, where she did her pre-med training. Karen has been a great addition to the program. I remember when she came here for her interview, and I was absolutely certain that we were not going to match with her because somebody had tried to break into her hotel room on the night before she interviewed. But as a trooper, she came to the interview, was completely composed, and did a good job. And so I felt like if somebody could handle that and still come in and do well, that was the kind of person that we wanted in the program. So I was very glad to see that she ended up here. What you may not know about Karen is that she apparently has a gift for picking winning NC2A basketball teams. And much to my chagrin, as I sit at the bottom of the pool and looking up at everybody who's atop the pool, Karen is one of those that has a good chance of finishing in the top three. So next year, wherever she is, I will make sure that I email her and get information about her picks next year. But today, she's going to be talking about bariatric psychiatry. And everybody, please give Karen a warm welcome.
Hello. I guess we just use this. All right. So yeah, today I'll be talking about behavioral interventions for weight loss and obesity. I have 5 objectives, and I'll go over them, but there's really just one big objective. So the first is to better understand the financial, medical, and psychological impacts of obesity. The second is to discuss current non-pharmacologic approaches to obesity in both the primary care and the psychiatric settings. To demonstrate the unique suitability of mental health professionals to treating obesity. To discuss multiple treatments for obesity, including easy-to-use behavioral interventions that can realistically be used in even the shortest of your outpatient appointments, and to briefly review my own experience leading a therapy group entitled Building a Healthy Lifestyle, which I'm currently in my 2nd group now. So those are my 5 smaller objectives, but my one major objective is to get you guys to seriously think about treating obesity in your own setting, in your own practice, because it's a pretty big deal. So this is a map of the United States, and it shows the percent of obese Americans. There are actually 65% of Americans who are overweight. This is people who are obese with a BMI of over 30. And here in Arizona, as you can see, we have 20 to 24% of our adults are obese. And so how much does this cost us? The answer is a lot. In 1998, obesity nationally was estimated to be a $78.5 billion cost. 10 years later, in 2008, it was $148 billion, so it's pretty safe to say that we spend at least $150 billion a year now on obesity. And the medical costs for an obese person are 42% higher than that for a person of normal weight. So financially, we would do best to treat these people. Obesity is responsible for 9.1% of medical costs annually, compared to 6.5% in 1998. And it's 8.5% of Medicare expenditures, 11.8% of Medicaid expenditures, and 13% of the money that you pay for your health insurance goes towards treating obesity. So if we reduce obesity, then maybe you might have less money to pay to your insurance company. Medical consequences of obesity. So I won't go over these extensively because I'm sure we all know them. What you might not know is that endometrial, breast, and colon cancer are more common in people who are obese, or you're at higher risk if you're obese for those, and as little as 5 to 10% of weight loss may result in decreased fat mass, blood pressure, glucose, LDL, and triglycerides. So if you hit 5% weight loss, there is a possibility that you can have some medical benefit from that, but it's really 7 to 10% is kind of the aim to be more certain that you're going to have medical benefit. Psychiatric comorbidities of obesity, this is kind of a chicken and the egg thing, so you can't really say one causes the other. Eating disorders are more prevalent in obese people, especially binge eating. Depressive disorders, anxiety disorders, and personality disorders. Oh, this is my favorite weight loss from the past, weight loss treatment of obesity, the sanitized tapeworm. I think that this one may actually have worked. So unlike the others that you'll see today. This is from a museum in Minnesota called the Museum of Questionable Medical Devices. If you find yourself in Minneapolis, I highly recommend going. All right, so social consequences of obesity. Discrimination starts young. In kindergarten, kindergartners rank their obese peers as among those they like the least. Obese children are more likely to participate in violence in school, bullying behaviors, either as victims or abusers, and they're more likely to carry weapons if they're boys, older boys. And girls who are overweight are more likely to abuse substances. And obese adolescent girls have lower college acceptance rates than those for non-overweight girls, even with a comparable academic background. So what happens when these kids grow up? Adult women who were obese as adolescents earn less, they more frequently remain unmarried, they don't complete as many years of school, and they have higher rates of poverty. These were not seen among men who were obese in adolescence, so it was unique to that gender. And also these findings persisted even when it was controlled for income and education level of the woman's parents, the woman's IQ, or her self-esteem at baseline. This is one of my favorites too. This is washing away fat with soap. So you get younger and thinner using this soap. All right, so what causes obesity? The answer is it's complicated. Like, you could have a whole week's seminar on what causes obesity, so I'm not going to go into all of that, but I will touch on some things. Energy imbalance. So, calories in, energy out, that whole eat less, exercise more thing. Can cause obesity. Medications. I went through what Stephen Stahl's prescriber's guide, and 41% of the medications in there had weight gain listed as at least part of the time. Obesity may help promote genetic survival. So this one guy, Dr. Gundry, is kind of a big name right now on this. He points out that if you are obese younger, you'll start puberty earlier, menstruate earlier, and therefore have more years of reproducing. It's not necessarily good for your individual health, just good for your genetic survival, because then when your childbearing years are over, you die early. So then you're not eating all the resources and using up resources that would go towards your offspring living. So that's one theory. Biological mediators, including neuroendocrine regulation of eating behaviors and activity levels, are important. So when we're born, we have this innate preference for energy-dense foods. If you put a drop of a sweet substance on an infant's tongue between shots, it can help them calm down. So there's a pleasure response that's kind of built in. Between the ages of 3 and 5, those children are drawn to foods according to only 2 criteria: sweetness and familiarity. So if you want to get your 3 to 5-year-old to eat something new, you either have to pair it with something they're familiar with and mix it in with that, or you need to mix it with something that's really energy dense, like covering the vegetables with cheese sauce or something. And then our preferences for carbohydrates peak at age 12. And after that, puberty, during puberty, girls become increasingly driven towards high-fat foods, obviously for reproductive reasons, and boys towards high-protein foods. Other environmental influences. There's actually several studies who've looked at mice that during the time that the mice were pregnant and lactating, they fed these mice really high-fat diets. And so these mice gained a bunch of weight. And they looked at the offspring of the mice that gained a bunch of weight during pregnancy and lactation. And the offspring grew up to have hyperphagia, decreased activity, increased fasting glucose, increased cholesterol, decreased leptin sensitivity, and increased adiposity, even though they were fed the same diet as the control mice. So just by nature of being exposed to a mom who was overeating in utero, changed their behavior as adults, and this has been replicated in several studies. And then finally, gaining weight may be a normal response to an obesogenic environment. For a significant number of people who are obese, we have protections in place to help us survive periods of famine. And so we're programmed to want to eat energy-dense foods. We're programmed to put weight on. We're programmed to eat food when we see it, when it's available. And we don't really have any built-in defenses against living in an environment that has too much energy available to us. So in that sense, becoming overweight is a normal response to an abnormal environment. So there's not necessarily something wrong or dysregulated in that sense with your patient. It's just that they're living in this very difficult environment. So this is a bath that you just soak. You soak in a bath and you lose weight. All right, so why can't I refer my patients to their PCP? So there's 3 problems with that. One is patients might not have a primary care provider, or if they do, they might never go to their primary care provider. The second problem is primary care providers often don't address obesity because they have too many other things to address. They don't get reimbursed for it. They feel the sense of futility or lack of patient interest. And then also, when it is being addressed by primary care, they're not really doing a very good job. So we need to change as a medical community how we're addressing this. So how are we addressing this? Wadden and colleagues did a survey of 259 patients who were obese about what their physicians had told them. And this is, again, what the patients were hearing, not necessarily what the doctors were saying. But 44.8% of the obese patients indicated that their physicians had not prescribed any of 10 common weight control methods. And the 4 most common recommendations that they reported hearing were a commercial weight loss program, medication, readings, and exercise. But I think this is the year 2000, by the way. I didn't have a date on that. And then, so that's how patients are looking at how they're being treated. So what are the physicians saying? The physicians, the study collected 101 self-reported physician surveys, and the top 5 interventions were physical activity, reduced consumption of food, reduced portion sizes, suggest a specific type of physical activity, basically diet and exercise. All right, and then this is 1987. This is 23 years ago. Basically the same recommendations, diet and exercise. So what does this tell us? Well, it appears that physician interventions for obesity haven't changed very much in 25 years, and they're really not effective. So something different needs to happen. And 2 of the most effective strategies for weight loss were not recommended in either of these, or not detected by either of these studies. Here's 2 more. There's obesity powder and Dr. Gordon's elegant pills. I don't think those worked. All right, so why mental health professionals? So why should you consider treating obesity? Well, 1, patients are twice as likely to attempt weight loss after speaking with a physician. So just by asking them about it, they're twice as likely to attempt to lose weight. Because the medications we prescribe often cause weight gain. We treat all the other side effects of medication, or a lot of them anyway, sexual dysfunction, dry mouth. This is a side effect of medication we prescribe, so it's something that we need to address. Patients with chronic self-defeating behaviors are our specialty. This isn't that different from an alcoholic. This isn't that different from somebody who has self-harm. So we're used to working with patients with chronic self-defeating behaviors. Also, appetite and eating behaviors are common targets of therapy. We already ask about appetite and eating behaviors and weight gain as part of our basic psychiatric interview. I mean, we're halfway there already. So we might as well keep asking about it. So why else? We already help people learn to navigate difficult environments. Remember how I said that in a lot of ways, gaining weight is just a normal response to an abnormal environment. And so in that sense, it really is about helping your patient learn how to navigate living in the difficult environment that we live in. And we help patients do this all the time with other difficult environments. By helping our patients, we're affecting the lives of others and are working to prevent disease in the next generation. Kids, after they're born, also are very influenced by the behaviors of adults around them. So that would be great if we could prevent obesity. I know you guys are probably all familiar, Michelle Obama, this is her big issue for now is childhood obesity. And also because the treatments for obesity, exercise and dietary changes are often good treatments for psychiatric illness. So it really does pair well with what we're already doing. A couple things about exercise. One, there was a study done to compare the efficacy of exercise with sertraline. There were 3 branches of the study: a home-based exercise, a supervised group exercise, and then medication. And they used sertraline 50 to 200 milligrams daily. And you can see the remission rates as defined by HAM-D score less than 8 after 4 months was 40% for the home-based exercise, 45% for supervised exercise, and 47% with sertraline alone. So really, exercise, unless you pull something, there's really no other major side effect to it as long as they're medically cleared to do so. So, might as well get them moving. All right. Other benefits are decrease in anxiety, improvement in global self-esteem, and improvement in self-perception. Okay, so we talked about how primary care providers are addressing obesity. This was the only study I found really that talked about psychiatrists addressing obesity. And this study I thought was kind of a little bit ridiculous, but I'll tell you why it's in here. So they surveyed 236 psychiatrists and found the majority of these psychiatrists reported regularly assisting their obese patients with weight management. I don't know about you guys, but most psychiatrists I know don't do this. And even the people who wrote the study thought that that was a bit ridiculous and that maybe people were misreporting what they did in practice. But there were some good things about this study, or informational things. So psychiatrists who perceive themselves as underweight or normal weight, so the psychiatrist talking about himself or herself as underweight or normal weight, were more likely to assist their patients by changing their psychiatric medications than psychiatrists who were obese. So that was 68% versus 60%, adds up to 128, another not so great thing about the study. But this does not mean that a change in medication is the best decision for the patient. So just because you're thin doesn't mean you're healthy. Just because you're overweight doesn't mean you're unhealthy. These are risk factors that we talk about when we talk about BMI. So if you have a higher BMI, but you're working out regularly, you're eating well, chances are you're going to be much healthier. And if you switch a medication because it causes less weight gain, but their mental illness is less stable, that's not going to be good for the patient either. So let's just make sure we're not comparing the two. All right, so 65% of psychiatrists did not receive formal training in weight loss for obese patients. And psychiatrists trained in weight management in medical school had higher efficacy expectations compared with those who haven't received training. So if you think that you're going to be more successful, chances are you're probably more likely to try this. This is supported by research in primary care physicians who were more likely to assist their patients with weight loss after being trained. So this study suggests that in order to best treat our patients, education on the treatment of obesity should be part of psychiatric residency. So that's something to really consider. Fat girl laughs and grows slim. This one may have worked, I don't know, but it sounds more fun than some of the other ones. All right. That's probably the before picture, I imagine. It could be the after, I don't know. Okay, so approaching weight loss with your patients. I'll just kind of quickly go over motivational interviewing. I'm more helpful for younger residents than you guys, but all right, so originally used to treat drug and alcohol addiction. It's also been used in diet, exercise, diabetes, HIV, medication, regimen, adherence, a bunch of things. Basically, it's good for trying to get your patients to do anything that is difficult to do. It's been shown to improve attendance of individual and group weight loss interventions and increase accuracy of food diaries. The stages of change model, I won't go over. So a central factor in motivational interviewing is non-judgmental acknowledgement and exploration of the patient's ambivalence to change his or her behavior. So chances are your patient has really mixed feelings about attempting to lose weight. They've probably lost weight 5 times and gained it all back, or tried to lose weight and been really unsuccessful in the past. So I could very easily hear somebody saying, you know, I would like to lose weight, I would like to feel better, but you know, I'm always miserable and I haven't been able to do it till now, so you know, I really have mixed feelings. Conversation is patient-centered, using the patient's own motivation. So you might be motivated to have them lose weight for their health, but they might be motivated to lose weight for a wedding. So, you know, also one thing I should say too about addressing obesity with your patients, this, you know, obviously might not be something that you want to do with a long-term psychodynamic patient where, you know, the patient's really leading everything. But it's okay, you know, especially with your medication management patients, to have your agenda for them too. So, but you want to make sure that you're using the patient's own motivations to change. And if they're not ready to change, or they're not even thinking about change, you know, exploring why that is. So, whoops. Emphasis is placed on acknowledging that it is ultimately the patient's choice whether or not to act. Yeah, we can't make our patients do anything. So ultimately, it really is their choice. So if you're going to give them that personal responsibility for their health that we really want our patients to have, it's really important to enhance their self-confidence in his or her ability to change. So the same can be true for us when it comes to treating our patients for obesity. Ultimately, it's your choice whether or not you address obesity with your patients. That's totally and completely in your hands. So I'm here to tell you that it's possible to be successful, it's possible for your patients to be successful, and it's realistic in a short time frame to make a difference for your patients. Motivational interviewing can acknowledge genetic, social, family, and cultural influences, but again, it's really based on the present behavior. And one thing about motivation I do want to point out is that persistent negative symptoms of schizophrenia may be a cause of low motivation and responsive to medications. So there was a case report that I read about a woman who was on olanzapine, gained a lot of weight on olanzapine, and over time, I think it was 6 to 8 months, her negative symptoms resolved. And at that point, she was able to be engaging and interactive and had a lot of motivation to exercise, change her diet, and she ended up being able to lose the weight. So if you have a schizophrenic who's gained weight on a medication, you may want to consider that more aggressive treatment of negative symptoms could result in motivation to lose weight. This one is kind of funny. This is basically a vibrating suction cup that's supposed to suck the fat out of you. All right, so principles of behavioral interventions. 1, it is possible to change weight by changing eating and exercise behavior. 2, these are learned behaviors, and like other learned behaviors, can be modified. And 3, to modify these behaviors long-term, it is necessary to change the environment that influences them. So this is my Behavior Theory 101 slide, which is, you know, cues lead to behaviors, lead to consequences. It doesn't really get more basic than that. So when we tell our patients, diet and exercise, eat less, exercise more, we're telling them to change their behaviors, completely ignoring the cues that are leading to those behaviors. So if you make patients aware of cues, they can either choose a different behavior, or if you change the cues by increasing them, you know, adding new cues, taking cues away, modifying cues, you know, if you change the cues, different behaviors should logically follow. So I think just this diet and exercise thing has really been the wrong approach. We really need to address what is triggering people to eat and not move. All right, so what are cues? Environmental cues, going to the movies. A lot of people will go to the movies and order popcorn even if they've just had a big dinner. They just want popcorn at the movie. After school snacks, I don't know, I still get home from work and want my after school snack. I go straight to the kitchen. And watching TV. So watching TV is interesting. Most people know that you're not supposed to sit in front of the TV because you can just eat a whole bag of chips and before you know it, like the chips are gone. But we're also just like Pavlov's dog, right? You know, Pavlov had the dog and he rang the bell and then he rang the bell and the dog salivated even though there was no food there. So we're the same way. You turn on the TV, if you're used to eating in front of the TV, you're going to salivate, you're going to start looking for food. So there's really more than one reason not to eat in front of the television. Social pressures, psychological cues, thoughts and feelings. So some people eat when they're anxious or upset. Physical cues, obviously hunger. People will sometimes, if they're in touch with their hunger, eat because of that. Which is a good thing. Seeing, smelling, and hearing food, just having it in front of you will make you eat it. Novelty-seeking behavior, if you're walking down the street and there's chocolate-covered crickets, some people, you know, will want to try that. And then interpersonal cues. So if everyone else is eating, you know, or here, grandma's like, oh, you're not, you know, you're too skinny, or whatever. All right, so when it comes to cues and consequences, I asked myself, what would Joel Dvoskin do? And for you guys who don't know him, he's a PhD who sometimes comes here and teaches motivational speaking and helping people maximize performance. So if we want to maximize performance of our weight loss, these are things that he would say. The first rule to affect behavioral change in another person is catch them doing something right. Your patient likes to hear, wow, you're doing a good job, that's great. So if they're doing something right, tell them that they're doing that. Acknowledge even the smallest steps towards healthier living. So your patient may start eating, oh, I started eating breakfast. Okay, great, that's great. You know, maybe they've been eating way too much, but at least now they're eating breakfast. Smile when patients tell you about positive changes, no matter how small they are. So, you know, doctor, I've switched to light beer. Well, great, that's wonderful. Let's get you drinking less now. So, and when trying to maximize performance in others, from all these studies, according to Dr. Dvoskin, the perfect ratio of compliments to criticisms is 5-to-1. So I would like to introduce the idea that the same ratio applies when you are trying to maximize your own performance, when you're talking to yourself. Giving yourself or giving your patients 5 compliments for every criticism is the best way to get them to maximize their performance and to change in a good direction. All right, so behavioral interventions. There's a bunch of them, and how do they compare to other weight loss interventions? So this is the first slide here. This is of less intense interventions that averaged 5 hours. And there's different ones here. There's self-help books, e-diets, Atkins diet, Weight Watchers, Zone, Ornish diet. And then the behavioral ones that are here are the diabetes education, support and education, the look ahead diet. I'll tell you what that is in a sec. And the learn diet. So if you go through, this column is mean weight change at 12 months. So the intervention that had the most change after a year was the Atkins diet, actually. There are two studies. This one had 68 people, and they lost 5.5 kilograms, I think this is. And then, or kilos. Anyway, they lost a lot. And kilograms. And the Atkins diet up here, they didn't lose as much. And then with the Learn diet down here, they lost 3.1. So, but if you look at everybody else, you know, 2.1, 3.2, 3.1, 3.2, 3.1 is right up there at the top of the list for weight loss and weight change at 12 months. The other really important thing is coming down here to this column, which is people who either did not lose weight or people who gained weight. So these are people who definitely didn't benefit and may have actually gained weight because of the intervention. You go down to the Learn program, which is this behavioral intervention, and only 21.7% of people lost no weight. That means that 78.3% of people lost at least half a pound. So you're definitely more likely to help, at least in some regard, and less likely to have no impact or a negative impact with the Learn diet compared to the other diets that had 47, 65, 60, 47, 50% of people who really benefited not at all. The Atkins diet, just to compare here with this study, it was still 28% basically. So you are more likely to do better on the Atkins according to this study, but you're also more likely not to benefit at all. This slide is for more intense interventions, averaging 37 hours. Going back to the first slide, this look ahead, diabetes behavioral intervention is part of that. That didn't do so well in the less intense intervention, but if you go to the more intense intervention, they had this huge study of 2,496 completers who ended up losing 8.6. So that was a very, and that was actually, the only ones that did better than that were the very low calorie diet and the low calorie diet, which I have some issues with, but can be very effective as well. All right, so look ahead. This is the big study that did really well. It's an ongoing multi-center randomized clinical trial to examine the effects of lifestyle intervention. They're looking to achieve and maintain weight loss. They're focusing specifically on type 2 diabetes and cardiovascular disease as outcomes. And then the other behavioral intervention that was listed was the LEARN program. This is a manualized treatment. The manual is available in our library, so if you want to go check it out from the library downstairs, you could get it. LEARN stands for lifestyle, exercise, attitudes, relationships, and nutrition. And there are 16 lessons that address each of those. So it addresses relationships, it addresses exercise, it addresses nutrition. And this is one that did really well. So this is something that you very easily could go through with a patient. All right, again, back to the basic behavior theory. So by adding, subtracting, and changing the cues, behaviors can change. So how do you do this? So self-monitoring is a way to really increase the amount of cues a patient gets and change the cues that they get that could lead to different eating behaviors and exercise behaviors. So self-monitoring provides new cues by increasing weight if you're tracking weight, increasing your awareness about it. Increasing your awareness of how much food are you actually eating if you're tracking food, increasing awareness of how much you're actually exercising when you're tracking it. It provides an internal focus for change. So if you're monitoring yourself, you're becoming very, very aware of what your own behaviors are. You're not relying on an external intervention. And you're really becoming more aware of your own participation in gaining or losing weight. And then continued adherence to self-monitoring predicts long-term maintenance of weight loss. The National Institutes of Health have a weight loss registry, and people who lose weight and maintain it long-term weigh themselves daily on average and often still keep a food diary. All right, so using a scale. You may have heard in the past that you're only supposed to weigh yourself once a week. That kind of used to be what they told you. So that is changing. One, because people who are successful at losing weight and keeping it off do weigh themselves much more frequently than that. Daily weighing has been shown to prevent weight gain in freshman college women. I don't know how many of them had eating disorders, but they definitely did not gain the freshman 15. When given a scale and told to weigh themselves every day, they didn't gain weight. This was also found to be true in an adult independent living community, and I don't know if I have that study cited here or not, but so that's been found also in older adults, that if they weigh themselves every day, they didn't gain weight. When fluctuation in weight becomes normal, you're not going to be distressed by this little blip in the scale. Daily weighing allows for early identification of weight gain and therefore earlier intervention. And also even inconsequential increases in weight can help perpetuate healthy behaviors. So generally it's good to have a weight range, not I weigh 150 pounds or whatever. You know, I weigh 150 to 160. It's good to have this range because your weight's going to fluctuate anyway. So if somebody has this range in their head and they're getting up towards the top of the range, they may choose to have a salad for lunch. They may choose to, you know, not have a second glass of wine or whatever. So that can help perpetuate healthy behaviors. Keeping a food journal. This is like the #1 best thing that you could ever possibly ask your patients to do, is to keep a food journal. It's proven to be a strong predictor of weight loss success. So the more accurate your food journal can be, the more likely you are to lose weight, period. It's basically a detailed record of the foods that somebody eats, and often physical activity is included in that journal. And again, weight loss is correlated with journal accuracy. So if you can really stress the importance of being accurate, you can even encourage people to buy a scale at home or to, use the measuring cups. So here's an example. There are two ways to kind of track your food. One is by calories and one is by serving sizes. People who've done Weight Watchers might be more familiar with the serving sizes. I think it's good to do both, and I'll tell you why. So this person had half a bagel with a tablespoon of peanut butter and coffee with 2% milk. So this is, like 80% of a great food journal, because they're pretty specific about the serving sizes and not so much with the 2% milk. But an orange, 62 calories, 1.5 cups of leftover spaghetti squash with tomato sauce, and then 2 cups chili Colorado with flour tortilla and a light beer, 800 calories. So the person who wrote this food diary might think, oh my gosh, I had this huge dinner. I had all this chili Colorado and beer and a flour tortilla, and it's 800 calories. Like, holy, that's like way too much. But then they add the calories up at the end of the day, and they're still just fine. So people may learn to feel much better and trust that they can self-regulate if, they come to this point where they're like, okay, even though I had this really big meal, I still did fine at the end of the day. They can also go back and say, you know what, I really didn't have that much earlier in the day. Spaghetti squash, there's like nothing in spaghetti squash. It's all fiber and water. So, and just this one snack. So they can learn, oh, I need to eat more at the beginning of the day. If you do it by serving sizes, I think this can be really helpful too. One, it can help track how much somebody's drinking, if you can track that. And if you do this every day, and you're constantly saying, oh, I only have half a serving of dairy, or I never get 3 servings of dairy, or you do this and you never put a mark in the fruit column, 3, 4, 5 days go by, and suddenly you're thinking, I need to eat some fruit, I need to eat some milk, or drink some milk, or have some dairy. So if you're keeping track of serving sizes, then that can really promote better nutrition. And just having that visual there, that's, again, you're just adding a cue. People will have different responses to different cues. So without these cues, they may choose to go, they come home from work and have Cheez-Its, I don't know. But if they're keeping track of this and they notice, oh, I haven't put anything in the fruit column for a while, they're going to go and maybe choose an apple. So that's how changing a cue can really change a behavior.
What is ETOH?
Oh, I'm sorry. The ETOH, there's a question as to what this stands for. That stands for alcohol. I'm sorry. Yeah. All right. I don't know why half this slide is blue. But these are different places online where you can keep track of how much you're eating, and you can put in and say, I had, a McDonald's cheeseburger or whatever, and most of them have the calorie content of that, the nutrition information for that. You can say, I've had 2 cups of grapes, and it'll keep track of everything you eat. It'll add up the calories for you. It'll keep track of nutrition for you. You can put in exercise in here, and it'll estimate how many calories you've burned. You can put a goal in there. Say, my goal is to lose 10 pounds in 3 months. It'll tell you how much you need to eat for your size to meet your goal on time. MyPyramid.gov has some really interesting things. It has some different cultural visual aids. A lot of countries have their equivalent of the food pyramid. So not everybody uses a food pyramid. I think it's China. They have a food pagoda, which is kind of exciting. There's a food rainbow. And so it can be fun to just go on and look at that. The other thing is sometimes the nutritional recommendations are a bit different too. In some of the Asian countries, they'll have a recommended daily intake of soy-based products and legumes, for example, and for us that's just combined with protein. So I would encourage you to check that out just because it's fun and interesting. But they also, I believe, have, it's pyramid.gov, it's been a while since I went through these, but have culturally appropriate low-calorie diet plans. So what does a 1,600 calorie day look like for people who are from the Deep South and eat mostly Southern food, or for people who are Latino or whatever? They have some different cultural low-calorie menus. But you can't keep track of your daily calories here long term. It's just a 24-hour website, but helpful nonetheless. There's still calorie counting books too that are available for people who prefer the old-fashioned paper method. All right, so a word on exercise. Exercise, yeah, it's harder to lose weight just by changing your exercise than it is just by changing your diet. So your patients are more likely to be more successful if you choose a dietary intervention over an exercise intervention first. Also, we have this really big resistance to physical activity sometimes in our culture, and it's not always that easy if you live in an unsafe neighborhood to go for walks, whatever. So having said that, sometimes, or there are several studies to show that encouraging decreased sedentary behavior can be a very effective weight control method, especially for kids. There was one study that they had one group of kids that had their internet and computer and video games limited. Said you can only have like an hour of this and then you have to go play and do something else. And then this second group of kids was assigned a specific exercise regimen. Well, the kids who were assigned the specific exercise regimen pretty much stopped doing it after the study was over, but the kids who had the decreased sedentary behavior kept being more active even at the end of the study, doing what they do best, which is playing and running around. So the same also has been found with adults, which is, oh, I guess this was the child one at the bottom. Limiting internet and computer time in adults may be an intervention that you need to discuss with adults as a way to get them to move more. You can burn, I guess, the individual variation in energy expenditure during the day just by fidgeting is like 100 to 700 calories. So just, moving around a lot more can burn some calories. All right, so losing weight is just the beginning. Both you and your patient should continue active monitoring of weight and weight loss long after weight loss has been achieved. So keep the daily weighing, keep the food diary for a good long while, if not permanently. Keep checking in on your patient's weight a year later, 2 years later. And also set a limit for how much weight can be regained before you need to restart active weight loss. So if somebody's lost 40 pounds, say, okay, well, when you've gained 10 back, we're going to start active weight loss again. You don't want to wait until your patient's gained the 40 pounds back. And it's glaringly obvious to the both of you that this has happened. So if you're continuing to monitor weight, even if it's just 3-month, 30-minute med checks or 15-minute med checks, you're going to catch that early. This is actually the same product, and I'm not quite sure why they had two different ads, one for fleshy people and one for fat people, because the text is the same, but. All right, so building a healthy lifestyle. This is the group therapy that I've been doing here, and I just wanted to share my experience with you guys as to how that's been going. So basically, it's a 12-week program for obese patients with or without a history of binge eating. And it was based on an early model of a program that's sort of in ongoing development at Drexel University by Evan Foreman, Megan Butrin, Kimberly Hoffman, and James Herbert. I've kind of deviated from that model more the second group than I did the first group, but it was based on their initial 12-week program. And then it's based on acceptance and commitment therapy, where the focus is on helping patients separate thoughts and feelings from behaviors. So the way I talk to my patients about what this group is about is that if you're going to lose weight and you're the kind of person who normally eats 4 pieces of pizza and now you're going to eat 1 or 2 pieces of pizza, eventually you're going to start feeling deprived. If you are at work and somebody brings in a tray of mini muffins and you're not going to have one, you're going to feel left out. How do you deal with those feelings of deprivation? How do you deal with those feelings of feeling left out? And those are the cues, remember, that lead to the behaviors that, that's often what caused people to fall off their diet is, oh, somebody brought mini muffins into work, or I really kind of want that 3rd piece of pizza. So this group really focuses on, okay, accepting that you're going to feel deprived. At some point, it's impossible to lose weight in America and not at some point feel deprived. But that doesn't mean that you have to eat. You can feel deprived and choose to go do something else. So patients learn to identify thoughts, feelings, and sensations that could lead to overeating. So again, they learn to identify their cues, and then they can choose different behaviors. Coping skills, including learning how to handle those feelings are taught. Patients learn to separate their internal experiences from their eating behaviors, and they learn to tie their long-term goals and priorities to in-the-moment choices about eating and exercise. So say a patient comes and they really want to lose weight because they want to be able to run around and play with their kids. Well, sometimes it can be hard to remember this long-term goal when you're faced with, you know, Oreo cookies or something. So learning to recognize that the decision they make in that moment is also related to something that they're working towards over the long term, and being able to choose a behavior that's more in line with their value system will feel really good for the patient. So with my program, I've ended up placing a much greater emphasis on reviewing and discussing food journals, just going over food journals with the different patients to a much greater extent than in their original program. And my patients have had a really difficult time keeping a food journal. This may be due to differences in treatment populations, but it's something that's really been a struggle for me. So since I've really changed that focus, my patients have actually done a lot better. And then I still go over coping mechanisms and all the other stuff, but I just spend less time on it. And concurrent visits with a dietitian certainly would be helpful, but this is an increase in time commitment, and your patients may not be able to leave work enough to go see a dietitian or something. But definitely refer them to see a dietitian, because it makes your job easier if you don't have to do all of that. So this slide is kind of, oh, I guess it's easier to see up here. So this doesn't look super impressive, but there is kind of a downward trend. So we'll go to the next graph, which looks way more impressive. And the first three, let me tell you what you're looking at. The first three patients here were in my first group. And then this patient number 3 decided to repeat the group because she really liked it the first time. And so these 4 patients are in my second group. So obviously there's a big difference in how the first group did in 12 weeks, and the second groups, I'm only on week 7. So this is how successful people have been after only 7 weeks of being in the program. And one of the differences, this group took place over Thanksgiving and Christmas and and Halloween, and so that may have something to do with it. All of the group members felt it was very helpful, and I was kind of surprised because they didn't really lose any weight, and so that shocked me that they thought it was as beneficial as they did. But normally they would have gained at least 5 pounds during the holiday season. So in their minds, this was definitely a weight maintenance success. And also, especially patient number 3, but also one of the other patients, had a lot of binge eating. By the end of the 12 weeks, her binge eating behavior had really, really decreased to be almost non-existent. Actually, if you treat binge eating disorder from a behavioral weight loss model, it's as effective as treating it from an eating disorder model. Plus, you might lose weight. So I would definitely recommend referring binge eaters to behavioral weight loss. So as you can see, she has started losing weight. She was kind of up here at the end of the 12 weeks, and now she's really kind of booking along. And these patients are doing much better too. So this is the last slide I have. That's a picture, medically approved bile beans. And oh, so what can you do starting today? 1, talk to your patients about weight loss. Like, just talk to them about it. They're twice as likely to try and lose weight if you just bring up the issue. Use motivational interviewing. It really works. Encourage detailed food records. So you have a patient that comes in. They come in to see you for their regular, refill of Prozac or whatever. It's very easy to just say, hey, I'm wondering if you're curious about maybe wanting to address your obesity. This is clearly this might be an appropriate place to do that. You can buy food journals at, Barnes & Noble or whatever. I have made food journals that fit in the pocket, so that patients can just carry them around in their purse or whatever. And say, here, use this, and this is can be a really effective tool, and the more accurate you can be with your food record, I guarantee you, if you do this, accurately for 2 weeks, I would have a really hard time if somebody didn't actually make significant changes to their eating habits. Even if they don't lose weight, they're going to be eating healthier, they're going to be more aware of what they're eating. And you can print off the internet, you know, portion sizes, that kind of stuff. And also that's also where referral to a dietitian can come in really handy. So you don't have to explain to them all the portion sizes and nutrition stuff. If you say, okay, I'm going to refer you to the dietitian, and dietitians will often go over food records with patients, and if they can come back repeatedly. Insurance companies will pay for dietitians often, so that's definitely a referral you can make. But just talking to them about this concept of weighing themselves every day and using a food record can really make a difference in a patient's life. So I hope that I've been able to convince you that this is something that you should address with your patients. It is possible to lose weight and keep it off, and I really think that changing from just telling your patients to diet and exercise to giving them specific advice about self-monitoring will really, really work. So that's it. If you have any questions, feel free. Yes? Thank you.
Very helpful, pointers. I was wondering if you can tell us what kind of, if you had any challenges trying to run these groups, and how did you overcome them?
Okay, the biggest challenge running the group definitely is recruitment. Getting people to actually come was a big challenge. So it's harder. I was kind of actually surprised. Why do I think? Well, you know, I put up a bunch of flyers that had, you know, my phone number on it and contact information. It was really easy for the patient to just, you know, reach out and grab my contact information, and nobody was calling. Like, even though all of this information had been taken off the wall, that behavior of taking it off the wall was easy. The behavior of actually calling and doing something about it was really difficult. So it would be very helpful, you know, if they had more people like their physician talking to them about what might be available. So this is actually something I hope to do in the community after I graduate. Exactly how this is going to happen, I'm not so sure yet. I'm going to figure it out after I'm done. But I hope to provide this service in the community of Tucson in years to come. But so you can definitely refer them to me when I get that up and running. So that was the biggest one. And then I've actually had some people show up who really got there and realized that they just didn't want to do it or weren't ready to commit. So it can be something that requires a major commitment. So if you have a lot of stressors going on, that might not be the time to say, okay, let's do something about your obesity. You know, if they're, you know, they just got fired and they're looking for a new job and there's a recession, you know, saying, okay, well, you know, maybe if they have some foreseeable future where things are going to get easier, saying, you know what, when things get easier, now we're going to address this problem, because it is hard. So that might be something. Yes?
Also, thanks for this is a great presentation and really well presented. I have a couple of questions. I don't know if there are any answers to them. In terms of comparative research on behavioral conditioning of people who are eating certain quality of food rather than measuring calories or amounts. In other words, we know just this big study that you probably know that just came out in the past couple of months showing that people who had our typical American diet, i.e. that insulin-resistant, high-sugar, trans-fatty diet, have significantly more depression. And so the question is, and there's this question, well, does depression cause them to eat that way or whatever? Well, that would make 70% of our whole populace depressed,
Right.
which, counting the number of antidepressants, would give up may be the case. So I'm wondering in that, and the second question was poor versus wealthy, if this breaks down in any way.
Okay. All right, the first question is, does it matter what kinds of food you eat? Is that a...
If there are any studies showing, comparing, trying to condition people to the quality of food, because they're going to lose weight if they,
Right.
for instance, on a Mediterranean diet, than just looking at calories or amounts in our traditional life.
Right. You know, I don't know of any specific studies about that, whether or not eating, the question is if you pay attention to the kind of foods that you're eating rather than the amount of food or the calories of food, is there a difference? Not really is the answer about specific studies. I do know that There is a lot of data showing that eating a lot of carbohydrates, for example, can cause more moodiness. Carbohydrate craving is part of PMS. There's a lot of links between depression and carbohydrates. Interestingly, one of the feedback mechanisms that tell you to stop eating carbohydrates is serotonin. So that might have something to do with it. Cortisol, cortisone, the glucocorticoid receptors stimulate wanting to eat sugar, so we're all stressed in America. That might cause us to want to eat more. So, and I have noticed, both personally and with other people that I know and people in my groups have also noticed this, that if you stop eating highly processed carbohydrates for about 3 to 4 days, your craving for that food goes away. And one thing that I ran across in the research was that if you decrease the amount of energy that you take in after about 3 days, your leptin levels go down. So I don't know if those are correlated, but that's just personal anecdotal evidence that is more related to quality of food rather than amount of food. Your second question was poor versus wealthy. I also didn't research that specifically. But I know it's being addressed nationally with the whole concept of food deserts and making fresh foods more available in inner city communities, that kind of thing. So the cheapest foods are really highly processed carbohydrate foods. So you have to maybe problem solve with your patients. If they don't have a lot of money, how are they going to eat healthier? I would like to recommend gardening, but actually that's not a bad recommendation. If you're growing your own food in your backyard, you're much more likely to eat an apple or tomato or corn if you just have to walk out the backyard to get it, rather than pay for it at the grocery store. So yeah, actually that's a great recommendation. So it requires backyard. That's true. Well, there's container gardens if you have a patio. You can grow plenty of things on the patio. Other questions? Nope. Oh, yes?
Food desert?
Yes.
What is that?
Food desert. So this is something that I've just learned about from, a lot of different sources. But anyway, basically, there are a lot of inner city communities where fresh foods are not available, where supermarkets used to be and then have pulled out of the community because they're not making as much money or enough money. There's a lot of convenience stores. There's a lot of people who buy cheaper foods, so they just stock a bunch of high-carb foods. So a food desert is an urban area or even a rural area, I suppose, theoretically, where fresh fruits and vegetables are not easily available. That might definitely fall into that category, yeah. So, anything? Yes?
Do you have any comment on the inducements that were offered to us attendees in the form of cookies?
Well, only to say that while it is good to limit your simple carbohydrate intake, I don't want to live in a world without ice cream. So, in moderation, everything. That's my approach anyway. But thank you very much. All right.